Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Nomogram to Predict the Benefit of Radiation for Older Breast Cancer Patients Treated with Conservative Surgery by Jeffrey M. Albert et al. My name is Clifford Hudis, and I am the Chief of the Breast Cancer Medicine Service and an attending physician and member at Memorial Sloan Kettering Cancer Center. I'm also a professor of medicine at the Weill Cornell Medical College in New York City. My oncologic specialty is medical oncology, and my practice and research are limited to breast cancer medicine. The name of this podcast is This Nomogram Ready to Roll? ? The role of radiation therapy in the treatment of older patients with lower risk early-stage breast cancer is evolving in parallel with other trends in breast cancer management. Consider for one moment the decreasing extent of local control surgery. Over the past decades, we have seen stronger evidence that limited interventions can provide equivalent long-term outcomes with fewer toxicities. So-called partial mastectomy or lumpectomy does not appear to compromise the curability of most patients with breast cancer. More recently, randomized trials have challenged the belief that axillary lymph node dissection is a required component of cure. Aging introduces an additional and important treatment variable. Clinicians already know this well enough, although it is sometimes difficult to capture its impact in prospective clinical trials. For example, with aging, there can be a relatively rapid increase in the impact of competing morbidities and all-cause mortality. Especially in the setting of low-risk breast cancer, these trends with age decrease the possibility of detecting significant improvements in disease-specific long-term outcomes. A generation ago, British investigators demonstrated the trade-off in morbidity that immediate versus delayed surgical treatment could yield in older patients treated with tamoxifen, and more recently, American investigators demonstrated the very limited downside of omitting breast radiation therapy in a subset of women over age 70 who were treated with tamoxifen for estrogen receptor positive, node negative, or unknown nodal status breast cancer. A very important subtlety of the American study was the observation that a substantial number of surgeons had not recommended or performed an axillary procedure in women in their 8th decade of life. This means that for various reasons and before randomized data were available, they were simply performing lumpectomy and not bothering to assess the axillary nodes. Their willingness to forego the axillary dissection at that time indicates that to some degree they were not planning to use the information to direct subsequent therapy. Without an impact on treatment decision-making, they deemed it an unnecessary intervention. This line of thinking continues to influence ongoing and planned local control trials and reminds us that clinicians should not do things just because that is how we always have. Instead, we should continue to ask, in the context of decreasing overall mortality and improving systemic therapy options, whether previously established standard procedures are still absolutely required in all circumstances. In this issue of the JCO, Dr. Jeffrey Albert and colleagues attempt to provide a tool to help clinicians determine when, on the sliding scales of risk, benefit, and increasing morbidities, radiation therapy will still be required in patients who have undergone conservative surgery for breast cancer at an older age. Their stated goal was to determine whether the omission of radiation therapy, previously justified by randomized trials in women with favorable disease characteristics, can be generalized to other groups of older women. The endpoint they address is long-term breast preservation with or without radiation. This matches one of the endpoints of the earlier randomized studies, but assumes no impact on distant metastases and death from breast cancer. Without saying so overtly, they are acknowledging the lack of an impact by local radiation therapy on overall and even distant disease-free survival in older patients with favorable prognosis breast cancer. They are likely correct, given that Kevin Hughes recently updated the earlier CALGB randomized trial and highlighted the overwhelming likelihood of mortality from non-breast cancer-related causes in this older population with good risk hormone receptor positive disease. Dr. Albert and colleagues relied on the SEER Medicare database to identify over 16,000 women aged 66 to 79 over the decade ending in 2002 who were treated with breast conservation with or without radiation therapy. They then linked this information to the performance of any subsequent mastectomy, estimated the time to mastectomy, and developed a nomogram to predict 5 and 10-year mastectomy-free survival rates. After 7 years, the estimates for mastectomy-free survival were very high and reassuring. After incorporating additional factors beyond age, including race, tumor size, estrogen receptor status, and importantly, the use of radiation therapy, all of which were to some degree linked to time to mastectomy, they developed their nomogram and demonstrated relatively good accuracy in predicting mastectomy. They conclude that their tool is clinically useful. Clinicians should ask how this improves upon the specific data already provided by the prospective randomized clinical trials conducted and reported in the recent past. Indeed, many readers will note that guidelines, such as those developed by the National Comprehensive Cancer Network, already state that women over age 70 with hormone receptor positive stage 1 breast cancer receiving adjuvant hormone therapy can safely omit radiation therapy. Given that prospective evidence, what is the prospective role? I'm sorry, I need to restate that last sentence. Given that prospective evidence, what is the potential role of the nomogram? One argument for using this or another nomogram in this situation is that patients treated in routine practice differ in ways that can be accounted and adjusted for from those in randomized clinical trials. The differences between clinical research subjects and patients who are treated off-study always exist and creates a possible barrier to adoption of clinical trials results. Current efforts to develop more comprehensive data capture across all practice settings are meant in part to help bridge this gap. However, the lack of prospective research planning and informed consent in routine practice previously means that investigators must rely on large but possibly inaccurate databases for work like that described here. A full discussion of the risks and benefits of using the SEER database is beyond the scope of my discussion, but we must acknowledge that there may be systemic biases or flaws in the data that would have an impact on the conclusion. At the same time, the perfect can be the enemy of the good, and clinicians in practice need to know how to apply the results of carefully conducted prospective clinical trials to patient populations that are not always exact fits. There are two possible approaches to this problem. On the one hand, we could say that a particular patient would not have been eligible for the earlier randomized trial, and therefore the reported results will not be applicable. This risks confusing the biology of a tumor with extrinsic and possibly irrelevant factors like a person's history of unrelated medical illness or injury. The alternative approach is to liberally generalize the results of the randomized trials and fail to account for the random, unpredictable, and potentially meaningful impact of selected comorbidities. Circling back once more to the CALGB trial, the fact that clinicians omitted the axillary dissection so frequently and that this was allowed speaks volumes about the acceptability and appropriate use of clinical judgment in the care of aging patients. Clinicians in practice are well aware of the need to incorporate diffuse and seemingly unrelated factors into their treatment decisions. However, when they are choosing to omit a standard and established treatment like radiation, they may tend towards a more conservative stance for fear of being perceived as compromising cure and harming patients. The proposed nomogram could provide them with the additional support for such decisions they need, especially in a broader patient population than studied by others in the past. In constructing their nomogram, these investigators relied on earlier evidence that they generated suggesting that radiation was very unlikely to be of benefit after age 80. Again, this is not necessarily because of a decrease in its effectiveness against cancer, but instead it reflects the impact of competing causes of mortality. They therefore limited the age of their study participants to no more than 79. They further excluded a variety of low-risk pathologic subtypes, patients without accurate staging information, those with distant metastases at presentation, those with bilateral breast cancer, or for whom a second primary breast cancer could not be excluded. They also excluded patients who died during a treatment interval and those with insurance that might have had an impact on their treatment. This left about 28,000 patients treated with conservative surgery for whom claims data supported a specific initial breast surgery approach. To focus only on the impact of unilateral breast recurrence, they excluded over 900 women who developed contralateral breast cancer subsequently, yielding just over 16,000 patients. Mastectomy rates were determined based on subsequent billing codes. They recorded the presence or absence of axillary assessment, receipt of radiation therapy, and additional factors such as age, year of diagnosis, race, and even Charlson comorbidity scores. Importantly, almost 90% received radiation treatment so that the no radiation group was relatively small. The low overall rate of subsequent mastectomy is reassuring at just over 3%. The 5- and 10-year estimates of mastectomy survival were about 98 and 95% respectively. They noted a significant association between tumor grade and receptor status and therefore only included the latter in the final model. They also noted that the effect size of radiation therapy varied with lymph node status. This is consistent with expectations based on earlier clinical trials. Once they developed a nomogram, they validated internally using the bootstrap method. A discussion of the technical aspects of this validation is beyond the scope of today's podcast, but it demonstrated good accuracy. What this means is that their nomogram provided mastectomy-free survival estimates that closely approximated those calculated directly from the data using Kaplan-Meier estimates. It is disappointing that these investigators were unable to incorporate the use of endocrine therapy, as this is clearly important in both local and systemic disease control. They suggest that this latter point is acceptable because they incorporate so-called average compliance with endocrine therapy, but this means that very compliant patients will have an overestimate of risk and non-compliant patients will have an underestimation. Is this nomogram sufficient for routine and broad clinical use? Interestingly, even though the intent was to enable application of clinical trial results to a wider group of patients, their population was not completely reflective of the diversity expected in the United States. For example, minority groups were underrepresented. There were few patients with node-positive disease or with larger tumors. Furthermore, for patients who have a very good prognosis and survival despite advanced age, and a nice tool is available at www.eprognosis.org, the fact that the nomogram only addresses the next decade represents a limitation. Finally, and more fundamentally, it would be helpful to see this nomogram validated using a completely independent data set. On the other hand, given the fact that many clinicians have withheld otherwise recommended interventions in older patients, such as axillary dissection and radiation therapy, and even treatment of the in-place primary tumor, in the past using only clinical judgment, this nomogram may be useful in bolstering their confidence in the clinic. In this case, it may serve as a decision aid or simply may provide clinicians with the courage to do what they already believe is correct. But its results are not a substitute for properly conducted prospective randomized trials, and again, additional and independent corroboration of its predictions is needed. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.